Good afternoon, everyone. I'm Ankit Sanghvi, Executive Director with Texas Health Institute, and pleased to welcome you for today's webinar, Artificial Intelligence and Oral Health, Evidence, Policy, and the Future of Care Delivery. I'm sure this is a topic that's going to unravel, and I believe we are only going to be scratching the surface in terms of the depth here. And pleased to have Dr. Chalmers join us. Throughout the webinar, we encourage questions from the audience. Please use the Q&A option in the bottom tab to share your questions. There is a dedicated time towards the end of the webinar to discuss those. Next slide. Before we get started with today's discussion, for those of you new to the Texas Oral Health Coalition, the coalition is an initiative within Texas Health Institute, and it's a statewide collaborative dedicated to improving oral health to advance the health of all Texans. Next slide. The priorities of the coalition are centered around the three areas of advancing access to timely, accessible, affordable, and acceptable care, protecting public health, prevention, and beyond, and bridging oral and overall health. We advance these priorities across or through our four strategies of advancing policy, collaboration, education, and research. We couldn't be doing this without the support of our partners and the many different communities and organizations across the state. But particularly for today's webinar, we are pleased to have the support of the Texas Department of State Health Services, CareQuest Institute for Oral Health, Cook Children's Center for Community Health, and Driscoll Children's Hospital. With that, I think we are ready for today's discussion. But just given the excitement around this topic and my own curiosity around this topic, before I kick this off to Dr. Chalmers, I would love to just take a good temperature check on the audience in terms of artificial intelligence and oral health and where we are as a community. Let's see. Team, can we have the responses?
They are still coming in, Ankit, if we can give it just a few more seconds.
Alrighty. Let's see. Wow. So as we polled, in your opinion, to what extent do you believe AI is changing or will change oral health? And an overwhelming majority towards a great deal. So I'm pleased with again the topic or focus for today's webinar, and given the excitement around this topic, as we had our discussions as a team, talking to some of our key partners on what could be the next topic, what should be the next topic, did artificial intelligence did definitely rise to the top, and curiosity around oral health. And as we were thinking about the mission, about the coalition, its work as a systems-focused organization and initiative, we started looking at the oral health system. And there are very few individuals that I have had the honor to know in my work over the last decade that have been engaged across the spectrum, whether it's being a clinician, being a research systems thinker, within the policy regulatory space, and also advancing innovation. And Natalia Chalmers doesn't need an introduction per se, but I just want to take this moment to share my appreciation and excitement, Natalia, for you joining us and the difference you continue to make in advancing oral health and health across the board. And again, this is an exciting topic, and I am just looking forward to the discussion. So without further ado, I'll pass this floor to you, and looking forward to seeing what you have to share.
Brilliant, brilliant. Wonderful to be here. And if we were in one room, I would ask all of you, raise your hand. When was the last time you saw two dentists look at the same X-ray and reach the same conclusions, right? In the next 30 minutes, we will actually understand why this happens, what we know about it, and how AI can help us resolve this. We'll look at it from a lens of a provider and policy and impact on patients and providers. So here is the promise. We'll look at the evidence, why we need it. We'll look at access to care because AI innovation doesn't happen in a vacuum. It is really important to understand where there are challenges, how they cross the medical and dental field, where there is an impact and overlay. Look at diagnostic variability. I don't expect you to become FDA experts, but I really want you to appreciate the evidence that goes behind these policy and development, how it impacts education, and how it is a support. I've seen this from many angles, as Ankit said, as a researcher, as a pediatric dentist, someone who's been in federal policy at FDA and CMS, and I'm really thrilled to be leading in the innovation. But the North Star has not changed. The North Star has always been better oral health, better access, better outcomes for children, adults, and seniors. And I think the future of dentistry is human-centered, data and evidence-driven, and very much AI-empowered. Wanted to start by a very quick reflection of how AI has changed your life. Amazon thinks that I should read every book written by Mel Robinson. Obviously, the algorithms in Netflix are all AI generated. If you love reading, I highly recommend a book, A Giant Leap by Dr. Retcher, is really insightful on how AI is changing medicine and healthcare. And if you haven't already, open evidence is absolutely transforming how clinicians access clinical evidence to inform patient care. And our headquarters are in San Francisco, so I had to put a Waymo car. I don't know if I'm ready for a car without a driver, but they're here and they're very safe. And I actually wanted us to start in medicine because this is one of the most exciting clinical trials that has happened, and it introduces very important concepts that will guide us understand AI in dentistry. And that has to do with the Massai study published in January, where the gold standard was reading a mammography by two radiologists and comparing that to one radiologist supported by AI. And I want you to appreciate these two very important terms that will come even more relevant when we talk about dental AI, the sensitivity and specificity. And because they often get confused, I want to give us a frame of how to think about it. And that's using the analogy of a fire smoke detector. So we want the smoke detector to go off every time there is a real fire, but we don't want it to go off every time we make toast. So let's go and look at the study. What happened is that the actual catching of new diseases, right? New cancers, the sensitivity improved. Okay, that's when the smoke detector catches the fire. But what didn't happen is the specificity didn't change. So this is when we make toast, right? That is really critical for understanding how AI works. This concept of human in the loop becomes critical in AI policy and development, is that ultimately the provider is the decision maker. And we need to appreciate also that none of these numbers are 100%. And also none of them are tunable. So I want you to just walk into this space understanding this is already here helping in medicine and that there are guardrails around the adoption of AI. But before we dive into the AI space, I think it would be very helpful to look at how the landscape of dental and medical care and where we see opportunities here. Here is something I wonder how many of you knew, is that if you look at the healthcare spending in the US, most people are shocked by this number. The dental comes in second. The first one is diabetes, and none of us would be surprised by that number. But if you combine dental in oral diseases and well dental, it is the second highest spending in the US healthcare. So we're not the footnote in the healthcare spending. It is pretty major, and therefore understanding how efficiencies can be brought into the system is really important. And here's the challenge. Our patients navigate two completely different healthcare systems, the dental and the medical. And on the medical, there has been quite a lot of action to integrate multiple provider records, imaging, labs, etc. And on the dental, again, patients operating different portals, their imaging resides differently. But my point here is that providing efficiency in any piece of the system brings a better patient experience and better provider experience, and we'll look into that. There are actually significant impacts of the lack of integration between the two when it comes to prescription, coordination of care, the lack of health information technology. We don't have time to dive into this, but they're all connected. And of course, we have seen that when people don't have access to the oral healthcare delivery system, they can end up in the broader healthcare system. And so I just wanted to highlight this here is that we will be talking about this piece of access, but of course, many of you know people who don't access the dental delivery system will end up in the emergency department where the care is delivered in one of the most expensive settings. And sometimes they have to be admitted, and that's even more expensive, right? So any opportunity to bring efficiency to the dental delivery systems keeps the patients where they could deliver and receive definitive care. I also want us to root us in very deep understanding of the spending in the healthcare system, the dental healthcare system, and understanding that, again, the total spending has grown about 66%, but very different when you look at the different payers in dental, private, out-of-pocket, Medicaid, Medicare. With private insurance growing only about 42%, 44%, Medicaid rose about 242%, and Medicare about 60%. Again, just the context of where all of this innovation is happening. And one interesting fact, and I wonder how many of you know, but in Medicaid, if you look at and break down the spending by category, diagnostic, preventive, restorative, how many of you would even come and imagine that 30% of the dollars spent in Medicaid are for imaging? And I would question us, do we extract all the intelligence that's there? And how do we do that? And artificial intelligence can help us do that in ways that we couldn't really do 5 years ago. We're also noticing trends in growth in restorative services. Preventive services seem to stay flat. Again, these are really important concepts because AI can help us identify disease a lot sooner where prevention really works. The other piece that's important is to understand that while innovation is happening both on the medical and dental side, there are significant differences of how and who pays for this care. In dental, the out-of-pocket spending is about 40%, and it's the highest for any piece of the healthcare system. Again, when you go to a physician, chances are you're not paying more than $7 out of 100, or hospital $2 out of 100. But for the dental system, that's about $40. And in some parts of it could be up to 66, right? So this is important because innovation and payment go together. And this is just another trend to show you that the trending by spending when it comes to hospital and physician has exponentially grown. This is why this is part of major discussions every day, and dental has stayed relatively flat. Now, this is the landscape in terms of access and understanding access to dental care. And the reality is that we have about a third of Americans that yearly do not see a dentist. Okay, how we reach and improve their oral health remains an open question. And I think AI can have a huge impact of bridging that gap. And then even when I say here they had both a medical and a dental visit, it doesn't mean that it was actually genuinely integrated. It means they saw a dental provider and a medical provider, but it doesn't mean that the two actually talked. And of course, we have this incredible opportunity where 9% of Americans only will see a dentist. And so how is that point of care operationalized to say, hey, what about blood pressure? What about your diabetes screening? And of course, we also have to understand that there are those that are completely disconnected from the healthcare system. And here's the real interesting piece is that insurance is actually a major driver for access to care. And I'll talk about insurance later on and how AISU can help in this space. But even when you have private insurance with dental, we have very good access. Private with non-dental, that results basically in 20% drop in access to dental care. And when you look at, again, public only, many more people see a medical provider than a dental or both of them. And so that presents just a huge, enormous opportunity for 85 million adults, right? Half of them almost will not see a dentist. And here's where I want us to really think about AI adoption broadly in healthcare. And you can think of it in 4 categories: clinical, direct to consumer, business operation, or hybrid, a combination of any of these. JAMA Summit report, it was an incredible summit dedicated to AI and advancement. I really encourage you to read that, and you have access to the recording. But generally speaking, the AI innovation is happening in one of these spaces. Now, if you look at medical, there are over 350,000 apps. I don't know how one chooses an app, to be very frank with you, but they're there. There are over 1,200 medical devices that are cleared, right? 3 in 10 people use a health app. And the summit paper said something, I would say it's a bit controversial. Every patient clinical conversation in the US may soon be accompanied by a live interactive AI agent. And this is not the future, we're here. So this is just appreciating the landscape. But here is, and I love that we're doing this with the Texas Oral Health Coalition. Houston, we really have a problem. And this is where AI is so powerful. And what is the problem? When you ask a number of dentists to agree, you can actually measure their agreement with something called the Cohen-Kappa measure. If we all agree, it's 1. Okay. If we disagree, it's less than 1. Okay. So dentists tend to agree when there is a piece of metal in the jaw. I mean, it doesn't belong there, right? But you see that they agree. There is an implant or there is a root canal filling because again, that is not natively there. Where we don't agree, or we have a very wide window of agreement, is about the bread and butter of dentistry, caries, periapical lesions. This is where there is a huge opportunity. And this is across all imaging modalities and all lesions. But yeah, I'll show you an example. Even when you limit it to bite wings and caries, we still don't have agreement. And what is even more remarkable is there's something called, so this was the intra-observer agreement between a number of dentists, but intra-observer is if dentists agree with themselves. And what's even remarkable is we don't agree with ourselves when someone is asked to, detect caries again or periapical lesions. And instead of fighting this diagnostic variability, I think it is time to embrace it and acknowledge it, understand it, and find the tools that can solve for it. And here's the example I promised you. When we look at caries and diagnostic variability in bite wings, the people who really know this stuff is the oral radiologists. They're amazing. They're able to agree basically 85% of the time. Or calibrated examiners. That's a very structured way of doing this work. General dentists miss 61% of lesions that a specialist can identify. That's a huge opportunity to miss disease that's really there. And nothing against dental students. We were all there. They are novices, so they don't tend to agree, and that's okay. Where people train also matters. So these are all factors that contribute to the diagnostic variability. And many of us were here when in 97 we had an article that basically said if you go to a dentist's office, if you ask 50 dentists for a treatment, they came up with all different kinds of treatment plans. And there is a peer-reviewed literature that supports this, where dentists were given to teeth to treatment plan, and they only agreed about 22% of the time. So again, for me, this is recognizing this is the reality. How do we solve for it and how we develop policy, payment, innovation around it? It's really exciting. And there are many factors that contribute to this diagnostic accuracy and variation. I've tried to rank them in about 20, and you can think of it, dominating factors. The lesion severity. We actually tend to agree much better when there is a big hole in the tooth, right? The lesion severity is really important. The imaging matters. They're substantial, moderate, minor. But the piece I want you to take away is AI can actually help modulate all of these and help us reach that consistency and standardizations that we search for. Here is another example, right? Sensitivity for early lesions. Dentists don't agree if they're there or not. We tend to agree better when they're cavitated lesions because obviously they're cavitated. And we all know that it takes about 30 to 40% of mineral loss before you can actually see it on an X-ray. So again, just recognizing this as the baseline of where we are and how AI can help us. Another way to think about these factors, and again, to acknowledge them, is that they also can do very much by the observer, our experience, our specialty, how tired we are. I mean, that is the cognitive load is really important. Image, nothing is going to solve a problem with a terrible image, right? So the image quality needs to be there in order for the AI to work. Lesion, viewing environment. The bright lights in a beautiful dental office sometimes can actually be a problem for looking at the very fine grades between shades of gray and community. So AI can transform this, can help us understand this better and address all of these challenges. In the next part, we're going to look at how this technology is regulated by FDA. You basically have 4 steps. You have to classify your device. You have to prepare the correct submission. You have to have the right information, and then you have to comply. This process is public. I want you to walk away here feeling empowered that you know where to find information about AI. Most of the things in dentistry are devices, and they can be classified in 3 categories: class 1, low risk, class 2, moderate, and class 3, highest. I work with our colleagues at FDA, and it was incredibly powerful to see how these technologies. I was actually at FDA when Overjet got their first clearance, really incredible. But I want to share with you that many of the things in the dental office are devices. You have implants, cements, and here is dental. Software is a medical device, is a class 2 device. Okay, so this is how they're regulated. And if you look at this industry, we're talking only about a 5-year history here that one can think of it in 3 eras, right? Initially, you had to be able to classify the core pathology, like can you detect cavities? Can you find the teeth, anatomy, like normal anatomy? Then you had to make sure that it's workflow integrated, and then you expand on the features. And now we have specialty, 3D, etc. And as I said, this is all public information on the FDA website. And again, just to highlight all the players in this space, right? In period 1, market entry, finding these core pathologies, entering, having Overjet getting the first dental clearance in the US. Then you have the workflow integration. It had to work with the practice management systems. And then you're expanding on all of the things that you can detect. And then obviously period 3, imaging, specialization, etc. And these are, again, FDA regulated. If you're seeking pediatric indications, you need to have a pediatric clearance. And here they are. I want you to bookmark this website. This is where all this information resides. So any AI tool that you have access to, if it's on the US market, should be listed under the FDA clearances on this page. You can click on each one. It should have the indication, the specificity and sensitivity you and I talked about. And again, I want to highlight one of the clearances that's very unique to this space, to Overjet, is we had to go to FDA and provide the evidence that we can provide the best clear images, regardless of a sensor, without impacting the diagnostic accuracy, right? That actually takes a lot of work in order to have this crystal clear imaging, and they work very, very nicely with our Iris native system. So, but let me move the curtain and help you understand how these algorithms are trained. And I want to make a note here that there is a huge difference between generative AI, these are the chat GPTs, the Claudes of the world, versus this AI that's for imaging. And they're trained with many shades of gray. Every image we take, every pixel has a shade of gray. You can translate this to a number, and the dentists, licensed dentists, are annotating thousands of x-rays and saying, this is a pulp, this is an enamel, this is dentin, this is a filling. All of that information, this is the bone level, is trained into a deep learning model. And then you have to establish the truth. What is the ground truth? You have, again, 75 dentists look at an x-ray and say, I think there is a cavity here, or this is a restoration. And the average of that helps you identify the ground truth and overcome this, what I just told you, that dentists don't agree, right? That diagnostic variability. And then what you can do is put a new image, a raw input of this image, and have through the algorithm, based on what is learned, to identify, this looks like pulp, this looks like a cavity, this looks like a restoration, right? Now the algorithm is trained. So as you see here, the only source of information for that is what the model is trained to recognize. And this is the beauty. You can put any image that the algorithm has never seen before, and it can have the findings. And for each one, we have sought FDA clearance, right? The tartar, the bone levels, the cavity, all of these are unique indications that come together in a beautiful way that you can communicate with patients. Here's an example, right? Now we can have this conversation instead of asking mom, and I've had this conversation multiple times where I ask mom, do you see the shades of, the triangles between the teeth? And of course, I'm talking about the cavity, but mom is looking about this triangle, right? So we can remove that ambiguity and help them understand here's the disease, here are the cavities, and now we have a different conversation. How do we treat them? So it's really removing that one point of tension in the dental delivery system between the provider and the patient. Instead of discussing if there is disease or not, is how do we manage all of these cavities? And some of them may be new. There is very strict regulatory guidance on how these AIs can improve. You have this as a reference. Again, this is all public information, but I wanted to highlight one study specifically that's really key for getting this technology on the market. It's called the multi-reader, multi-case study. And in that particular study, you have to show that the clinical performance, okay, with and without AI. And guess what? If the clinical performance doesn't change, the AI doesn't make the cut. So you need to bring and you need to show value to the clinician, right? That these softwares as medical devices can support clinicians in diagnostics. Then you have to do, again, these are all things that are required. If you're seeking pediatric validation, you have to have those studies. Cybersecurity, independence, all of these things are part of the regulatory process. And the specificity and sensitivity of these models, they're out there in the submission. So you have access to them. Remember, specificity, sensitivity based on the lesion, based on the X-ray. But beyond diagnostics, and this is what really gets me excited and the impact on public health and our ability to drive innovation in the dental space, is that we really now see this technology moving into a space of great promise. And I'll share with you a few examples. Obviously, we are trusted in the dental ecosystem. We work with many practices, many payers. I'll talk about this in a second, and many, many schools. And these publications are driven with some of these partnerships. So I will start with one of the most exciting things that happened last year is the publication of the Oral Score Basic. It's the first AI-driven oral health metric that can be used in a validated and reproducible way. And what I mean by that is that every major specialty has a standardized health metric. We don't. For diabetes, in order to have a strategy, you can have A1C. This is why people can have, for blood pressure, whole initiatives, because they have something they can measure how it's improved or not. BMI, of course, you have obesity. And here is the opportunity for oral health. We have developed the Overjet AI-enabled oral score, where, as I showed to you, these are all the images and the annotation of all the pathology that is on those images, including the periapical lesions. And I'll talk about this in a second, right? These can be missed with an intraoral exam. Basically, you have a full picture of the pathology, and then you can produce an oral health score for one patient and another patient. I will be the first one to say this is why we call it the basic. This doesn't include all the other risk factors that we know, diet, risk factors, soft tissue, right? But radiographically, if you have a full set of, this is a full mouse series, then you're able to, the radiographic score of the burden of disease. Imagine if you knew what provider had, let's say they have 1,000 patients, what is the average burden of disease in that practice or that state or that health plan. It really changes the game of understanding the impact of oral health. And we are really excited to partner and launch a program in Oregon to launch this with the providers. The other piece that AI can do very well is bring incredible efficiency to the system. This is a partnership with Harvard University where manual, analysis in identification of periodontal disease, of course, providers can do that, took about 10 minutes, okay? But with AI, the providers were able to do this in 1 to 2 minutes. And what providers do with these 8 minutes could vary, but I always think about access. 8 minutes over many patients adds up to perhaps another new patient in the chair to bring that efficiency to the system. Or here is another example how we can measure impact in learning. This is our work with great partnership with University of Florida. Even the D1 students, these are year one, they were able to improve using AI in understanding and defining cavities. I would just say it's really great to see the D3 students starting at a better place than D1. Education really works. But what was so meaningful here is that they were able to significantly improve their capacity of understanding the disease. And then this stands for periapical radiolucency. I wanted to share this with you, and you show me highlight this example. D4, D3s, these are again, it's good to see the D4s are performing better than D3s, but AI outperformed them all. And I will show you now how important was the lesion severity. Remember with caries, I showed you, we don't agree on the early lesions. We tend to agree on the cavitated ones when there is a big hole, right? Same holds true for these ones. So here's what I mean. The large lesions, actually D3s and D4 students, they did pretty good. Okay, remember, none of this is going to be ever 100%. They did pretty good because they're big lesions, right? Where AI was incredibly helpful was when the lesions were very small. And again, their untrained eye, again, D4s are doing better than D3s, but you can see how this is so helpful to move forward that understanding of the disease. The other piece I want to share with you, and we have to talk about this, is, is the system ready for AI? And we loved to hear how the students felt this was incredibly easy to use. It enhances their detection. It improved patient communication. This is a big one. We actually see incredible response from the patients. They love it. For the first time, they're not guessing shades of gray. They actually know if they have the disease or not. But there are gaps. Is the curriculum ready for these new providers who have to walk into a system and maybe a DSO and a clinic that's using it? Is the faculty ready? Are they confident in integrating AI in their workflows? And I think this is a really key one. They're still very concerned about their own skills of diagnosis. And the analogy I would say is we want our students, or we want our providers, we want everyone from a policy perspective to learn how to drive a car before you enter and drive in a self-driving car. And I think that will remain the baseline, is that needs to be even more important and more integrated in the curriculums as we move forward with any applications in AI. The other piece here is that in a very busy practice, this was certainly our practice, when you get tired, when there's time pressures, we actually reduce our ability to diagnose the basic things like cavities. Okay, it's even worse when you look at how we diagnose periodontal disease here. So that becomes a real challenge. And AI doesn't get tired. So your eyes are the same Friday afternoon at 5 o'clock as they are Monday at 9 o'clock, right? And in addition to this, the ability to have analytics, to have all of these images together, overjet voice like ambient recording is absolutely transforming the healthcare space and the dental notes and the accuracy from a compliance perspective. There's just our providers are producing the best notes in their career. And in order to do that in a very easy and seamless way. The other piece is that you can do scribing, you can do periodontal charting. Instead of 20 minutes, you can do it in 4. It's as easy and flexible as you want. You can chart your hard tissues. This again can take hours per week from providers, and you can generate letters, an incredibly powerful platform. The other, I've talked about one tension in the healthcare delivery system. That's between a provider and a patient. Is there disease or not? And what do we do about it? But the other one is with payers, right? What is it needed to have this prior authorization reviewed and approved? And this is where AI is incredibly powerful, is that when you have the proper documentation, and we work with over 300 payers, and you have the findings and the payer criteria, you can have almost immediate approval. And if there is not enough information, then you can say, well, this needs to be reviewed by a clinician. And so I think this is a really important and empowering thing that can help both providers and payers reach agreement and identify where proper care is paid for versus not. And I really want to spend the last few seconds talking about what AI is not. I think we all recognize this space. Yes, it can find the pathology, the radiographs, increase diagnostic confidence. This is great. We love the feedback that we hear from patients because for the first time they're recognizing their disease. We had a 4-year-old who said, I mean, it's nice when 4-year-olds don't have cavities, but in this case, the 4-year-old's like, oh, mom, look at my cavities, right? This is how easy it is to recognize the disease. But AI will never replace the clinician. Ultimately, as I showed you, there is specificity and sensitivity, and they're never going to be 100%. And the clinician is the ultimate decision maker here. They will never do an exam. They will never diagnose. They will never treatment plan. And they will never replace the need for a good radiograph. As I told you, the radiograph and the interpretation of that and the models are trained on images that have high quality. And if you have a bad X-ray, that nothing will replace that. We also need to talk about informed consent, right? How do we tell our patients about AI? I can tell you, I walked into a primary care setting and there was a note, ambient listening in progress, right? In Maryland, that was sufficient for me to have an exam with that in progress. But I think we need to have a conversation. Transparency, safety. What is the safety of the information? How is that all handled? Biases, HIPAA compliance, all of these things need to be part of the conversation. And I know you guys already, I see the chat binging, so I'm sure there are great questions here. But now you've looked at the evidence, you know why we have the access challenges and how improvement in one part of the system in AI can help us improve the ultimate goal, which is more people getting access, understanding their disease in ways they've never done before. You actually understood that we have diagnostic variability. And instead of fighting it, we're actually embracing it. And we're saying, that's fine. You're going to have 100 providers in your network of dentists. Chances are they're not going to agree. Let's bring the tools that will help them reach that, independent FDA-cleared algorithm on what really is working. You now understand what it takes to be on the US market and the FDA regulation and the threshold an AI needs to meet in order to be on the US market. You saw the impact on education and clinical practice and how this is a decision support for dentists to help them do better. I know there is a lot of questions, so I will turn it over to you, Ankit, for the questions.
Thanks, Natalia. Again, there is so much, and there's a lot to unpack here, and I appreciated the framework you used to organize your discussion today. One of the early slides you shared, where you had the pie with the number of residents in US being able to see a dentist or a physician or both. And when you talked about like we have almost close to 35 to 40% that are not able to see that clinician or just out of the system. And just given the context you provided, but also the potential you have unpacked here, how do you see AI as a tool for access? And I think it's particularly important both for the mission of the coalition, but also Texas has had this chronic need or challenge with insurance coverage across the board, not just for dental and estate. With the high insurance rate, we have the rural topography of our state. How can we use or look at this to answer or help address some of our access to care challenges?
I think this is really an important piece. And if I may share, I think this is just to level set. I don't know if you can see the slide can you see the slide? Let me see. I think this needs to be this needs to be part of the conversation. And this is a little bit closer zoning into Medicaid. I mean, we have states where 75% of children are in Medicaid. I want us to think about this because are we going to have enough dentists? Do we need more dentists? Or do we need to provide efficiency in the system so they could see 75% of kids in that state, right? The other piece I would say is we know oral health starts at birth and early. And again, we have in some states, 60% of children are in Medicaid. I mean, think about this for a second. That is the births are covered by Medicaid, like 40% nationally. The reason this is important is that if we don't understand the landscape, we cannot really see the potential of how AI can help. And I want to get, this is the point you're getting here. Access and coverage doesn't mean that even children where oral health is mandatory have access to care. In some states, we still have 30% of kids being seen. And so my question here is, if we have a state where only 30 out of 100 kids are being seen, how many more dentists are needed? Or do we bring efficiency to the clinic where you can do early diagnosis, really maximize on the power of AI and early detection? Because guess what? Prevention only works, right, when you can detect disease early. And AI is powerful. You saw, we don't agree when they're early lesions, but we can do a lot when we find them. And so bringing that efficiency, that early diagnosis, that focus on prevention actually saves a lot of time, because now you're treatment planning a much shorter visit versus a huge restorative visit, right? If we catch disease early, we can be more proactive. And again, to me, this is all about helping the providers do their best with the time constraints, with the workforce shortages we're facing, with all of these together. Because all of a sudden, right, to see everyone, even in Texas, we're not going to have 100,000 more providers. It's just not going to happen. And so how do we do, what are the pieces of efficiencies we can instill in the system to open the door for more patients? And we are seeing this actually. We're seeing it where providers are embracing diagnosis with AI to detect disease early and schedule frequent preventive visits, right? They're opening the door to more patients because they're not waiting until the advanced stages of disease where you have to have the hour appointments or an hour and a half appointments. This model is really, really exciting. And guess what? With AI, we also have all the minimally invasive dentistry that helps us get there. I think it's about putting all the pieces together and saying, yes, within the system we have today, not some future state, let's bring that efficiency. Let's help providers catch the disease early so we have that opportunity for intervention. So for me, prevention and access actually go very much hand in hand. Prevention only works when there's no disease. And so we need to catch that very, very early.
Yeah.
And I want to just highlight the scribing piece. I mean, how many of us have been at 5 o'clock typing notes, feeling completely burned out? Okay. Guess what? If I and my staff can leave at 5 o'clock, tomorrow we're here even more committed and happy to provide access and open the doors for more patients. I cannot overstate how important this is for provider well-being and also for good note taking and just having the documentations that we all want to have. It's just we never had the tools to do it, and now we do.
So well said.
Yeah. Mm-hmm.
But and Natalia, I appreciate and if I share back, right, I appreciate you first recognizing that when we think about access, right, we need to think beyond coverage, and I think again with Texas and our realities, and I can say that for several other states across the country, going back to it's the affordability, it's the availability. And acceptability. I also appreciate you saying it's rather than thinking about AI solving one part of the problem, how is AI helping us kind of look at it broader and connect the dots. So appreciate that. I see a lot of questions in the chat, but again, kind of I have this pressing question, which I think speaks to some of the themes that I'm seeing in the questions from the audiences.
Okay.
In spite of the potential, and I appreciate you kind of putting into context that we are still 5 years in this journey and we have already gone through 3 phases or generations of adoption. We are still if I'm not mistaken, we are still in this early stages of adoption, right? Across the spectrum. From your experience, what do you see as the key barriers? Is it lack of information? Is it trust? Is it infrastructure? Is it cost? That's inhibiting, private dental practices, community-based clinics from embracing or utilizing this as a technology, as a tool in their toolbox.
I love it. I love this question so much because we see this across the board. And first of all, I would say we all have followed the adoption, the adoption line. And this is going to be true here as well, right? You're going to have the early adopters, the mid and the late. But I would say the four things that come to mind. First is institutional readiness. Are you in an organization that's ready to embrace AI and really explore how it can help you? This could be at the DSO level. This could be at a single provider level. We have it at FQHCs. And again, sometimes they're already doing all of this on the medical side. I told you, I walked into a medical office, ambient listening is already in progress. How do we bring that efficiency to the dental side, right? How do we say this is the same conversation? I would say that institutional readiness is very, very key. Some organizations are fully embracing it, and some providers are embracing it. I'll give you an example with medical providers. They're now walking into health contracts, and if AI scribing is not part of the deal, they don't sign. Remember, a few years ago, we actually had a job that was like a medical scribe. It was a human being who was doing this job, right? We're not doing that anymore because there is a much more efficient way of doing it. So the organization needs to be willing to make that investment to help providers, to help patients and understand that. We see this across the schools. Some are ready and fully committed. We're so happy to launch partnerships with universities, and that's a leadership decision. They're seeing that this is the future and they're embracing it early. And others are somewhat hesitant. They don't know what it means. None of us were trained in this space, right? They don't necessarily understand the difference between generative and non-generative AI. So there is a lot of education that needs to happen. The second barrier I see is this medical dental data divide that we keep talking about, right? But I think AI is really helping integrate all the pieces on the medical side. So I'll just give you an example. It is possible now to go in a huge electronic medical record and basically use AI to summarize the thousands of pages that, again, it's humanly not possible to do as a provider with a clinical visit. Why are we not doing that on dental, right? And again, there are innovations in this space that are very, very exciting. Another one that I just shared that's genuinely really meaningful is when you take multiple images, right? Again, dental, so kind of this like painful process of scrolling. It's like, oh, tooth 19, I took one, 6 months ago, and now it's another one. And the system that we typically have in our offices are not designed for this chronological, what I need to communicate to my patients. So there are new solutions. Iris is the one that Overjet's developed that are trying to address some of these system, like the PMSs are not designed to provide that data. The third one I would say is economics. You touched on this, like how does this work? Where is the infrastructure, the cost for all of this? The most beautiful thing we've seen is we actually seen adoption across the board. From FQHCs, we have many FQHCs who are using Overjet today, to the single practices, to the multi-practices, and here I would say range from 10 practices to hundreds of practices, right? So we've seen this work across the landscape. And it's again, those leaders who have the vision to understand it and actually immediately seeing the benefit. I just share one story with one of our colleagues who implemented it in their ambulatory surgical centers. And immediately, like a surgical case becomes just a narration, transformative for their workflow. So it is possible, and they are seeing the benefits. But I think education, and you touched on the last that I think is another barrier, trust. If people don't understand, this goes for me as well. If I don't understand the technology, I'm not buying it. So I need to understand how you got from A to B so I can communicate to my patient, this is what it means. And when the AI has correct, findings, I'm confident, I communicate them. And if there is a disagreement, I can say, well, this one, I as a clinician can, say, I disagree with that, right? That's fine. I am ultimately the decision maker, but that trust is really, really important. I cannot understate, there's some confusion, someone would say, oh, just tweak the sensitivity and specificity. You can't do that, right? Like FDA clearances are there for a reason because you stand behind the cleared algorithm for your device. These are regulated devices because it's so important to trust that process that it's been followed. And actually, I just want to share this. This is a very expensive thing. It's not like, oh, I had, an algorithm and here it is, FDA approve it, right? If people invest in that trust, millions of dollars in order to have something that can serve patients and providers really well.
Love it. And I appreciated the way you opened on just like willingness or readiness before you embrace and go down. I also appreciated the way you closed on trust. And speaking of that, like for those of us who have chosen to be on the clinical path and from clinical also in public health, the values that is ingrained in us is do no harm. And at times it stops us from doing some good here and there. So what I'm seeing here is a lot of potential, but at the same time, um, I would say curiosity or skepticism that in the process of doing good, this also is a question that we received from our attendees. Is is there like as the way we explore this and the more we think about the use cases, um, is there a possibility that AI will lead to over diagnostics, wastage, harm to the profession or to the patient as part of our pursuit?
Yeah, I love this question because we need to be upfront about it, right? Like, what is the benefit and risk? And this may be my FDA head, but basically, you never put a drug on the market without weighing these two together. What are the risks and what are the benefits, right? And so this is very important conversation. But let me go back to that first scenario I shared with mammograms. Okay, what happened? What happened when AI supported a clinician? We were able to detect 30% more early cancers that, by the way, are life-saving. Early diagnosis means early surgery, less complications, probably adding 10, 20 years to that person's life. That has incredible value. Again, I'm just using that example of two radiologists versus AI and radiologists. The AI didn't change what treatment was going to happen. I hear this thing about treatment, over treatment. It's like, no, the AI had nothing to do with what protocol for surgery or chemotherapy happened for that patient who was diagnosed with breast cancer. But it actually had a lot to do with the early stage diagnosis. So I think we should not confuse the diagnosis validity here versus what a provider chooses to do. They will be providers, and I will be very upfront about this, who will see a very early lesion and say, I know prevention works. I was one of those, right? Let's floss, brush, put fluoride, varnish, silver. I mean, I would list all of these options before lifting up the handpiece. That is a clinician-driven decision that has nothing to do with AI versus not AI. You were just able to see the disease a lot earlier. And I think that has to do with how we're trained, where we see value, how aggressive treatment planning is. Remember that example I shared from the Reader's Digest? The treatment estimates range from $1,000 to $10,000. That is because the severity of treatment or the aggressive was very different, right? So that has not changed. How people would treatment plan has nothing to do with the identification of disease. I would flip that and say, frankly, for some of these, if it's not early diagnosed, prevention is probably out of the question, right? If we're only catching things way late and when we only can do fillings or crowns, we've missed the prevention window. So for me, AI is actually opening the prevention window. And I think we need to just really, really be very, very upfront. This tuning that I talked about, that is a no-go. Like you cannot be tuning a sensitivity to find more things. That is a no-go. An algorithm that's cleared by FDA should perform at that level. And want us to understand this, right? Because that sometimes can lead to these misconceptions of what it can and cannot do.
Yeah. I want to bridge and also want to be mindful of our time here. I see a lot of questions that I
Yeah, I
want to
can't
lift
believe the
up.
hour is almost gone.
Yes, so that gives me some ideas for us to continue this discussion. But before I sort of like get
Yes.
to that part of closing us out, I do want to raise one question from the Q&A that ties to the point you just raised around
Okay.
prevention and bringing it to Texas, right? Like again, when I think about like just the missed opportunity and the need we have for the number of Texans across the life continuum that have not been able to see a dentist for years, and in some cases, even a clinician for that matter. How can you think this technology can help us rethink, um, overcome the limitations or the lack of awareness of the importance of oral health to overall health, and in ways we could basically leverage this to equip our medical colleagues, our public health colleagues, to bridge that divide?
I love this question so much for so many reasons. And this is one reason why I shared the oral health score and the innovation that Overjet has brought in that. Because, Ankit, with all the work that we've done in any state, but also including in Texas, can we actually say in this county in Texas, the burden of disease is 60%, 70%? Like, can we say per patient, we deeply understand the burden of disease? I've seen this from many seats, and I can tell you, people don't know. And people don't know what they don't know, right? They're making decisions around policy and coverage without genuinely understanding that there are people walking with broken teeth, periapical lesions, active abscesses. Like I mean, this is the story of many of the patients, and we have never had an objective way of measuring this. Imagine if tomorrow you can go to a legislator or a plan and say, hey, I now know that you just happen to be in the county where the oral health score of everyone is 99%. Good for you. Let's do prevention. Like things are good, right? That is a different conversation in walking with someone and saying, I've looked at your constituents. The oral health score in your county is 30, 40, the maximum is 60. You have now a way to communicate burden of disease. We couldn't do this before. We were relying on outdated only oral exam surveys that were not capturing the full burden of disease. And again, some of the policy decisions are made without knowing it. I would argue that, again, a legislator knowing the burden of disease will make the right decision if they had the data. And sometimes it's finding ways to quantify it, share it in a way that makes clinical sense, and say, hey, also from a reimbursement perspective, treating people with oral health score of 90, let's put all the prevention in place, but they're good. When we're 30, 40, what do we need to do? Is the coverage actually adequate? Again, we've never had this at the state level or the plan level, even at the provider clinic level. I
Yeah.
am genuinely excited of what this would do for dentistry and just recognizing, oh, and by the way, to your point, communicating to the medical side. I mean, my colleagues, and you've heard me say this before, I was the chief dental officer that never talked about teeth. I talked about chronic inflammation because that was the common language with medicine. But imagine if we had a number that we can share with the medical providers and they actually understood it. I was like, everybody knows 20 is bad and 90 is good. And so we've never had that. To me, this is technology is giving us a way to communicate with the medical providers in ways. We don't have time today, but if there is interest, I would love to explore this more and also use cases around value-based care. Everybody talks about value-based care, but I can tell you the same way 10 dentists don't agree if there is a cavity or not, 10 dentists don't agree what's value-based care. And so how do you integrate this knowledge? I call it like it's intelligence that we've never had before into a value-based program design. I think it's incredibly promising.
Yeah. This is a wonderful segue to bring us to the closeout. I'm going to ask the team to bring up the slides, but want to recognize a couple of things. I think, Natalia, first of all, there is so much you continue to do and so much to learn. I just appreciate every opportunity to collaborate, to interact, to learn from you. And thank you again for doing this for us. I do know that I've not been able to get to many of the questions in the Q&A, which says a lot about the discussion and the potential. So I'm going to ask for those of you who are still on the webinar right after this, you should receive an evaluation opportunity. And this particular one does have a question that we need your feedback on. Like, is it just me? taking this assumption that there is interest, or it's something that we share as a shared understanding. And if it is true, I would love for you all to share your ideas or topics. Natalia, I think also speaking to your last point, this is a tool for systems design. And again, as I think about the role of the coalition and the larger story here at the Texas Health Institute, that's very much part of our pursuit and mission. So thank you again for opening my eyes and window to something that we should be thinking as we think about oral health in this larger health system, population health system design as part of our mission, and work to move the oral health and health for all Texans. With that, again, it was nice to see many familiar faces, names, and several new ones. Again, the coalition is an initiative of under THI, Texas Health Institute. If you or our organization wants to get involved, there are formal ways through partnership opportunities with the coalition, and then there are informal ways such as joining today's webinar. So please do join us and support. I think I also have one more slide. The recording for this webinar will be promptly available. And again, if you want to see a part two, maybe a part two, part three, please do respond to the evaluation for this webinar. And your feedback will shape our decisions and offerings moving forward. Again, Natalia, thank you so much for joining us, for sharing your knowledge, your wisdom, and your passion with us. And thanks to every one of you for joining us. I hope this was helpful and appreciate everything you all do to make a difference and make people healthy. Thank you.
Thank you so much.